our next speaker is Dr. Anuradha ma'am. Ma'am is the head of the department UVA services, Aravind Eye Hospital, Coimbatore, and ma'am will be speaking on molecular diagnosis and medical management for infective uveitis.
Thank you, Dr. Neetu and the Scientific Committee of Drishti 2025 for inviting me to talk on molecular diagnosis and medical management of infectious uveitis. When I think of diagnosis of infectious uveitis, I think of, it's something like trying to identify the culprit of a crime. So more often, you have to go by circumstantial evidence, by looking at the changes the organism has made in the eye or in the body, by either recognizing the clinical pattern or by imaging or serology. But ideally, if you want a definitive diagnosis, you should be able to isolate the organism either by smear or culture from the tissue. Now, you know that the sensitivity and specificity of these two tests is rather poor. And many of the organisms which cause uveitis, like viral and toxo, it's not very easy to culture it. So then the next best thing is to identify the genetic material of the organism in the tissue by means of molecular diagnosis. So I just want to go through the types of molecular diagnosis that are available to us. The oldest of which is the polymerase chain reaction, or the PCR, which is very much currently in use. So what it does is it's able to identify the genetic material, whether it's DNA or RNA, which is very specific to the organism, and it's able to amplify it, million times, so that from a small amount of the ocular fluid or the ocular tissue, you are able to identify the organism. Now, there's a new kid on the block. It is called the CRISPR-Cas diagnostics. So basically, this is a technique that was used for gene editing, and what it does is, it's able to really pinpoint a particular part of the DNA using a guide RNA, and using Cas9 or Cas12 scissors, it's able to snip it, very precisely. Now, how is it better than the PCR? It's far more sensitive, far more specific, and its turnaround time is something like 1 to 2 hours. Also, unlike the PCR, which needs a very sophisticated lab setup, this one in future might be able to give you bedside diagnosis, within a couple of hours at a lower cost. So this has already been tested out in fungal end-off and in fungal keratitis. Now, the very important limitation of these two techniques is that, before you order the test, you have to have a fair idea of the suspects. You have to name them, you have to have a differential diagnosis. So when that happens, you will be missing out on something you didn't suspect clinically, or you will not be able to identify a new pathogen which could potentially cause uveitis. So there's something called metagenomic next generation sequencing, which is able to pick up all the genetic material in a given sample. So including that of the host DNA. And this, you eliminate the human read and you compare it with a genome database. And it's able to identify up to the species level. Now this might sound, very exciting, but the cost of setting up this is, really, really high because of the large amount of reagents needed and the complex equipment and the need for data crunching. So with that, let's move on to the medical management of the most commonly seen infectious uveitis, starting with the anterior uveitis. The most common ones is the HSV or the VSV anterior uveitis. And usually you don't need an AC tab for this because clinical diagnosis is enough. And I hope it has not been covered already and it's not a repetition. So if you see a unilateral recurrent anterior uveitis with corneal involvement, iris atrophy, and often associated with a raised IOP secondary to trabeculitis, you kind of know it is viral. If you don't have these typical features, you can go for an AC tab and send it for multiplex PCR. And your treatment consists of mainly systemic antivirals. And we give Valsivir 2 grams to 3 grams per day for 10 to 14 days. And to control the concomitant inflammation, you have to use Predfort, which is a preferred steroid. And if there is an active corneal involvement, you can add on the topical antiviral treatment. For recurrent or chronic cases, you have to keep them on maintenance therapy with Valsivir 500, OD to BD for anything up to 1 year, sometimes even longer. So unlike the herpetic anterior uveitis, CME anterior uveitis is more difficult to diagnose clinically, even though they're supposed to have these coin-shaped KPs and nodular endothelial lesions. So the ACTAB for PCR is indicated more commonly in CME anterior uveitis. The treatment usually consists of ganciclovir gel, which is given 5 to 6 times per day for up to 4 weeks. If the uveitis is very severe, atypical or prolonged, you add oral valganciclovir, which is 900 milligram BD for 2 to 3 weeks, and then taper down to 450 milligram BD. Along with this, like with other herpetic, you have to add Predfort to control the concomitant inflammation. I think the infectious posterior uveitis has already been extensively covered. Let's look at the treatment for ocular toxoplasmosis, which can present as either a de novo unifocal retinitis or as a reactivation, like in this case. So you have systemic treatment and you have intravitreal treatment. The intravitreal treatment is now gaining a lot of popularity. But the mainstay of the treatment is systemic, usually with Bactrim, clindamycin, or azithromycin. This may be supplement or sometimes even replaced as first-line therapy with intravitreal clindamycin with or without dexamethasone in cases where you have severe retinitis, vision-threatening retinitis, or where systemic therapy is contraindicated or not tolerated. So I want to share my first case, and this looks like a repetition actually. This is the third case being presented in the UVS session in this KSOS. There's a 49-year-old female treated elsewhere for floaters and decreased vision in the left eye. She has received oral steroids and 2 doses of IVTA. So at presentation, you can see the view is very hazy because of the IVT and the vitritis, but even through that haze, we could see very extensive retinitis. So she was sent for media clearing vitrectomy with vitreous biopsy and PCR of the vitreous sample. And POD1, you can see the very extensive retinitis involving all quadrants, and the tab turned positive for toxoplasma. So this is an atypical toxoplasma because of localized immunosuppression from the IVTA. And she was treated with a combination of Bactrim with intravitreal clindamycin and dexamethasone, and you can see the response. Again, when you have the typical presentation of herpetic viral retinitis, diagnosis and treatment is very straightforward, which is injection acyclovir 10 to 15 milligram per kilogram body weight given 8 hourly as a slow infusion for 7 to 14 days, followed by maintenance, which could be with valacyclovir or acyclovir. We generally give Valsivir 1 gram TDS for minimum of 3 months. In the active phase of ARN, we also like to give injection ganciclovir 2 milligram as an adjunct treatment because the combined therapy is supposed to have better results. We should not forget the role of steroids in ARN because they typically have significant vitritis, vasculitis, and sometimes optic neuropathy. And you should use adequate amounts of systemic steroids under cover of the antiviral. Now, this is my second case, which is a 13-year-old girl presenting with a sudden onset, rapidly progressing loss of vision in the right eye. You can see the necrotizing retinitis in the right eye. There's vasculitis, and you have these multiple retinitis lesions throughout the fundus. And the left eye is showing an early retinitis involving the macula. Now, this presentation, didn't quite fit in with any of the known patterns of viral or toxo. So we knew that we were looking at trouble. So straight away, she was sent for a vitreous biopsy of the right eye along with the baseline workup. We also considered the possibility of SSPE, subacute sclerosing panencephalitis. Now, she turned out to be HIV positive, and the TAP turned out to be positive for HSV1 and negative for all the other organisms. She was treated with IV acyclovir followed by oral valsiclovir, and you can see the response to treatment. The classic CME patterns have already been discussed. Now, the one thing you should remember is that a CMV patient, CMV retinitis patient, is immunocompromised until otherwise proven. So the two main arms of treatment is, one is identifying the risk factors and improving the immune status, which could be HIV, could be iatrogenic immunosuppression, or a malignancy. So you have to take care of that. The second line is, the second part of the arm is treating the infection, which again you got to remember that it's not limited to the eye. CME retinitis usually means there is, in an immunocompromised patient means there's infection elsewhere in the body. So ideally you should treat it with tablet valganciclovir, 900 milligram BD given for 3 weeks, and then reduced to 900 milligram OD until the lesions resolve and the immune system recovers. Okay? And you can supplement this with local therapy. Local therapy is not to be used on its own because it doesn't protect the other eye if only one eye is involved, and it doesn't clear the systemic infection. And then the preferred agent is ganciclovir, 2 milligram. You can give it once or twice a week, and then on a weekly basis as maintenance until the infection resolves. Again, ocular TB has been discussed in detail. Now, the main line of treatment is ATT, 4 drug. We use 4 drug for 2 months, and then we give 2 drug for the remaining period. Minimum is 6 months. Some people use up to 9 months. Whether you should use systemic steroids in TB or not, that is still debated. Some cases, you might just get away with giving ATT alone. And if it's a vascularized lesion, granuloma, you can give intravitreal anti-VEGF. Certain cases, there are case reports of intravitreal moxifloxacin being used, to speed up the resolution of the granuloma. In case of inflammation which is not responding to steroids, so you get paradoxical worsening, we have even tried intravitreal steroids under ATT cover. So this is a HIV positive patient who is a defaulter, Manto negative, HRCT normal. The media is very hazy, and all you can see is these yellowish lesion. You don't even know whether it's retinitis or choroiditis. So these cases, you have to go for an early tap. And this one, I thought it's a retinitis, but this one turned out to be positive for TB. So the molecular diagnosis, may not be required when the lesions are typical and response to treatment. But in case of atypical presentation, hazy media, unreliable serology, which is often the case with an immunocompromised patient, poor response to treatment or recurrence, you will have to go for molecular diagnosis. And a lot of new techniques are on the way.